And our invited guest this afternoon is Dr. Majake. She is the Director of Clinical Services at Steve Biko Academic Hospital. And for those of you that are not familiar with Pretoria or are from out of the country, that is the academic hospital that's linked to the University of Pretoria. And it's, in terms of the public sector, it's highly rated in South Africa. And she's also a public health medicine specialist, like lots of the other uh, invited guests for the town hall. She trained at the School of Health Systems and Public Health at UP. So she's one of our alumni, and she's also an extraordinary lecturer in the school as well. So I think maybe we can then start with the first question from my side, and then if you guys have any questions, you can also post those in the chat window or raise your hand. So essentially, I wanted to focus today's session on hospital management. The students this week are covering, I think, quality of care, and they're also looking at health information systems, but we haven't really discussed hospital management during this module. Our focus has mainly been on sort of health systems in general. So I think as somebody that's sort of worked in hospital management within the private and public sector, maybe you can kind of tell us what managing at hospital entails and what sort of skills are required from a management perspective to do that sort of work. Over to you.
Okay. All right. Thank you very much, and good evening, all. So managing a hospital is essentially just administrating a hospital, and I just always equate to how we all run our personal lives, where you just make sure that your budgets are in check and you live within your resources and you function optimally. And so managing a hospital is exactly that, and it's slightly a level below leadership. So when you're a manager of a facility, in whether it's private or state, what do you look at? You look at the fact that you render a service. What type of service is it? It's healthcare service. When the patients get in, from how they get their files opened, that would be the administrative component of the hospital, to them then getting into the ward. When they get into the ward, they need clean linen, they need to have a clean facility. So that, of course, would be the supply chain management component of it. And who needs to welcome them? It ranges from, your UAAs or your receptionists, all the way to your nurses. So you manage the human resource component of it as well. And then, of course, when your patient is there, they need to be taken care of. So they need to have blood tests done, medication given, etc. And that would be the pharmacy management component of it. And then also you would have your allied workers, your physiotherapists, your OTs. But also they need to get fed. So then you also have your hotel services, which we refer to as your clean linen and your food and so forth. But also they need to get protected. So you need to have security also looking after these patients, and anybody for that matter who's looking after, who's utilizing the hospital, what we call the health establishment user. And what is important is you need to make sure that that hospital can survive. So you need resources, financial resources for it. And that's when you would have your financial manager step in, whether it's private or public. And they would work quite closely with your patient admin manager, who then looks at medical aids, which we call funders. That's another fancy term for medical aids. Look at day-to-day payment of those medical aids through the case managers, and ensure that we're not falling behind with regards to payment to survive. And of course, then you need to make sure that you've got your doctors, and if it's a private sector, it would be more your general manager that does it, and if it's your state, it would be your director of clinical services, that your doctors that come in and work on your patients are actually well accredited, you know, and they're actually who they say they are. So if they say they are a cardiothoracic surgeon, that they are a cardiothoracic surgeon. So it's essentially pulling together all the different facets of healthcare resources in a hospital environment, in a nutshell.
And perhaps we can focus then more in terms of your role as a medical manager or a clinical manager. What does that role entail? And is there an equivalent in the private sector? Because I'm not aware. I think in the private sector you just have hospital managers who are not necessarily clinicians, but maybe you can just talk about that a bit.
So when we initially think of a hospital environment, I think especially if you're clinicians, you know, so I see we've got a lot of nurses, a lot of doctors and so forth. We focus so much on giving the medical component of it, but it also needs to be quite succinctly managed from an operations perspective. So you actually need to have two strong people who would then do the operational bits, which would be your CEO or your general manager in private, and your clinical component. And so your clinician, or the clinical manager rather, would be looking after the doctors, allied workers. You're talking about quality now, so making sure that various facets of the hospital are run efficiently from an infection prevention control perspective, from a patient safety perspective. They would then look at various trends and look at, for example, do you have a hospital that's got high fall rates? You know, I'm laughing when one of the doctors said they've got a very small hospital that's 36 bedded, but is it 36 bedded of old people? Is it 36 bedded of young people? Because all of those come with various types of risk factors. So that's what you would manage. What is also important when you are doing the clinical component of management is you need to be up to date with the latest trends from a medical perspective. So various things like programs you would put in STEMI projects, or you would put in, management of stroke projects based on the type of hospital that you're dealing with. And I think another thing is, you know, so you asked the question about whether or not we do have that in private sector, and the answer is absolutely yes. It's a new discipline that's been incorporated into operations component of management, I think 4 years ago. So I think you will recall when I started in Mediclinic, I actually started as a clinical manager before I went off into general management. And that was basically because a lot of the operational managers, which are the GMs, would be your accountants and so forth. And so you need to have a bridge between your doctors and your general managers, who would then understand the environment. And so that's basically what a clinical manager would do. States is slightly more different in the sense that that's where all the best practices are learned. So you don't really have to look at the programs. You know, we've got Professor Makunyan and so forth. We've got your Professor Kakaza. They would actually come in with the programs and say, look, we want to do this. Management, can you help us with X, Y, or Z? So your role then in there would be to ensure that there's support for your HODs to do work, and also for your clusters. Because remember, we've got different levels of hospitals. And so if you're in a central hospital, your duty will then be to support your district hospital, and just to make sure that you tease out just how optimized your referral systems are, what is working. And if you look at a hospital like Steve Biko, it spans right out to Bronkhorstspruit, supporting Mamelodi as well, all the way to Mpumalanga in the various province. So there's a lot more that you would do that's a bit more strategic, because from an academic perspective, you're more than covered with your clinicians, as opposed to private sector where everybody works independently. And then you need to try and see how it is that you're going to streamline your different components. So, you know, if you're a hospital that does orthopedics, you look at the fact that funders want you to go more, arthroplasty route, and they've got different packages that they put together. So you see how you can be responsive as a hospital to make sure that your funders are happy with the package of service that you give, and that your doctors are then in agreement with how that will go about. So that's basically the difference, Sahendra, with regards to that. I think another thing I also just want to squeeze into this, I'm trying to think if I must wait until later, but I think it's also appropriate is, when we think of healthcare, very few people, and I love the fact that you've done health systems, because when you talk health systems, you talk the WHO building blocks as well, and finance is a big component, and very few people actually realize just how critical it is in your performance as well, from a clinical management perspective. So before I go into state, let me go into private sector, where for you to be an optimal hospital clinical manager, you would then have to do what we call cost per event. That's quite a huge chunk of the work that you need to look into, where you look at your theatre utilization, you look at your pharmacy utilization, you look at your length of stay as well. And you need to make sure that you don't fall off we call it OE ratio, observed versus expected ratio, because if you fall off as a hospital, your funders are less likely to want to continue to have you in the networks. Because remember, in private, you belong to certain medical aids, but then if you're not efficient in your costs, then you might fall off the networks. And efficiency in no way means that you are basically underservicing the patient, but it's about making sure that you stretch the rand so that you do the best for the most. And it's interesting because it's exactly what's mirrored in state. State looks at much bigger volumes of a population that's very vulnerable. And because they're vulnerable, they tend to have far more other comorbidities as well. So they're much sicker patients that require more. And so you have to stretch that rand as well. So you will often find that management, and there tends to be a disjunction now, and I'm really happy to see that more and more heads of departments and more nursing managers are engaging in this type of course, because when management starts talking about efficiency, length of stay, etc., you then understand that it's not really just indicators that are there because there is poor insight into medical management, but rather that we want to make sure that whatever service you deliver, if you're a clinician, you can actually continue to deliver it for longer, because we can stretch the rand and become efficient. So when you look at the domains of quality, accessibility, affordability, efficiency, all of those really equate to all these things that I'm talking about. And that's when we know for sure that we're giving quality in healthcare.
Thanks for that. So I think perhaps then we can talk a bit about the skills that are needed to do the kind of work that you do and the kind of work that other hospital managers do. And I think it would be useful kind of for the students to see the practical application of what they're learning. So what sort of skills do you think I needed to do your job?
Okay, so as cliche as it may sound, I think first of all you need to have a very strong baseline career. So all the ones that I've seen, environmental health, nursing, medicine, and so forth, you need that. And I think sometimes we really intimidate ourselves unnecessarily. And it's interesting because when I was initially offered a job in Mediclinic as a clinical manager, I actually pulled out of it. And I remember human resource saying, but why are you opting out? And I said, because I don't think I'm ready yet to do this job. And they said, well, why don't you give it a shot, and then you can see how it goes. And, if you're happy, then you can stay. And needless to say, when I got in there, it's smooth sailing. You just needed to learn bits and pieces here and there, but the baseline was fantastic. And of course, having had public health medicine, I mean, really it just made everything so smooth. So you certainly need to have a baseline qualification, because you need to have some sort of foundation that will then serve as a navigation route into anything you do. So if you're listening to this and you're an engineer, don't doubt and think, oh, maybe I can't actually get into hospital management. The answer would be absolutely not, because we need you for infrastructure. We need your knowledge in infrastructure. Engineers are very good with process engineering as well, so that would be good. But certainly management is also quite important, so you would, and I would definitely recommend something like public health. I think for me it's worked. It's really opened up so many opportunities, both in private and also in state. And funny enough, I didn't really have much of a financial background, and I didn't really do an MBA or do finance for non-financial managers. But I found that the crutches I had from my MEd were more than sufficient. But I think also one of the best skills that you can ever have if you want to really succeed as a manager is you need to be able to open yourself up and be vulnerable and realize that you're not there because you need to try and prove a point in terms of knowledge, but you're there to coordinate. So remember, I spoke about management being administrative and you basically doing administration. You need to work with your team. That's very critical. And you need to understand that, even if you're a doctor as a clinical manager, you're going to learn a lot, even from the receptionist. You're going to learn a lot from the patient administration manager. You will learn a lot even from the security manager. So that's a critical skill. Public health, we talk a lot about Ubuntu and community, just being part of a community. If you don't have that skill, you might survive in management, but you're going to struggle to actually really make that a sustainable part of your career.
I was just thinking that I've had lots of complaints during this module about group work, but it's so vital that you be able to work as a team in terms of management.
It's critical.
Yeah, and so I think if we can talk about a public sector hospital, and obviously in South Africa with sort of limited resources, there are a number of challenges in terms of you managing a public sector hospital, regardless of the level. Can we talk through some of those challenges? How one might go about addressing some of them. Yeah, I mean, I know you've only been back at Steve Biko for a very short time, but you've obviously had prior experience there as a registrar as well. So maybe you can kind of talk through some of those.
So, for me, I find the word challenges sometimes gets used as a barrier to progress, and also just hinders the ability for us to then explore other ways in which we can actually come up with the solutions. And so I've now switched my mind from challenges to gaps and opportunities. And I think one of the biggest challenges, gaps and opportunities within state, and it spans everywhere, it doesn't really matter whether you're in South Africa or wherever you are, is the fact that really the bottoms-up approach that we've been talking about for such a while, it's still there, and we just really, it's slow to gain traction in terms of primary healthcare reinforcement. So if you are in this session and you are a huge funder, or you belong to one of those NGOs that actually fund healthcare systems within Africa or elsewhere, we really need to start working towards PHC, because the bulk of our challenges are based on the fact that we have so many people, so there's such a huge demand, but the facilities only have X number of beds, and so we cannot really render the type of services that we want to render. And yet so many of those elements could have really been caught on primary healthcare level. And we really need to start working on that. We've been talking about the ward-based outreach teams for a while. We've been, most clinics have been opened, and I think there's something like 400 additional clinics that have been opened post-94, but they still close early. So they close before people come back from work. And I think we need to start looking at just basically how do we revolutionize the system itself. I think that's the biggest challenge. But back home, on hospital level, I think one of the greatest challenges we would certainly have is the demand. So it reduces the beds. Bed availability is basically a challenge. And I think when you look at the fact that, Professor Goodler-Brown used to talk about the theory of, I think it was Poussin's law, that the more beds you have, they're going to be filled. A bed created is a bed filled anyway. And so when you do create those beds, nonetheless, the other challenges, the people who are going to look after it, we still have massive brain drain in South Africa. And so now what we face is, okay, so we've got the beds, we've got the theaters, we've got the ICU, but we don't have enough ICU trained nurses. And I think that's why when you look at the Human Resource for Health document, we've been pushing for, mid-level workers, but there is no expression for them. So, if there's a clinical associate in the group, the question would be, how much time have you actually spent in hospital where you and did you ever gain clear expression in terms of the work that you could actually do? So that's one of the challenges that we definitely have. Another big stumbling block is the infrastructure when it comes to IT. Information is so crucial for us to plan adequately, and it's just so important for us to be responsive and understand the type of cases, and we don't have that at this moment in time. We're still trying to find ways in which we can create business units, which would be absolutely fantastic, and it's also a nice way of really decentralizing management, because you rope in HODs, and you rope in other facets of the different components of human resources to be active players in managing their different spaces. So that's also another gap that I think is definitely there. And I think those are the main ones. And of course, funding. We can see currently that with the high unemployment rate, we've got less people who are actually contributing towards the overall fiscus of the country. We've got more people who are ill, and we've got severe budgetary constraints. So those are also some of the challenges that we actually face.
So maybe at this point I can ask, in terms of the impact that COVID-19 has had on managing a hospital, has it become more difficult? If I'm not mistaken, Steve Biko doesn't actually have COVID wards. Those are handled at Tshwane District, but I might be mistaken. So, but what is the impact been with respect to COVID?
COVID-19 has had a major impact in all levels of human resources and just managing. So the first thing is you've had to have strategies because of the nature of the agent itself. You've had to have strategies of basically isolating patients and having specific wards to try and ensure that you limit the spread of COVID amongst the patients who do not have COVID. So that has been the first thing. And I think once you then start, having different sub-units within a hospital, you need, again, human resources that can look after those specific people. And with the current shortage, it's just made the shortage even worse. Even when you look at the theater, if you have a mom who is COVID positive that needs to be operated on, of course, you can't really push that emergency cesarean case till much later. So we've had to look at innovative ways of making sure that there will still be ongoing theatre, availability for cesarean sections, while we still have cater for those who do not have COVID and ensure you don't cross-contaminate. But then again, you look at the anaesthetists, you look at the obstetricians that need to do it, and the fact that you would then have to split them or get additional ones. And I think what's difficult as well is that when the numbers go down, you'll try to look at the backlog. So, your surgical backlogs, etc. But then you still need to have this business of looking after COVID cases, and they still need to be staffed. So it's had a massive effect from a finance perspective, because even in state, we've had to use agencies, just as was the case in private, to ensure that services still continue, whether you've got COVID or not. So it's been quite a huge challenge. And of course, you doing all of this with a human resource base that's already drained, tired, and stressed. It's really difficult because there hasn't really been much time, and the programs that you would want to have to make sure that you still have mental health rehabilitation for all of these cadres of staff that have really witnessed high levels of morbidity and mortality as well. So it really has had a massive impact.
I'm just going to pause just to check if there are any questions from the class at this stage. Any questions? You can put it in the chat window or raise your hand. I see the last person said that they're the HOD of ophthalmology at Steve Biko. So there's somebody you might know or should know.
Hi, Prof. It's Prof. Makunyan.
Yeah. Nothing at this stage. So I think I think for the remainder of the session, I want to focus on the two areas that we're really focusing on this week, which is quality and health information. So in terms of quality of care, um, I think it's important for the students to know. I think we've gone through the theory in terms of, the dimensions of quality, your quality improvement processes from a sort of theoretical point of view. But what is in place? And I think maybe we can talk about this both in terms of private and the public sector. What are the mechanisms and processes in place to ensure that your quality of care is appropriate, and you're not also delivering a substandard service, also not putting people's lives at risk. So what are those mechanisms?
Okay, so the first thing is you would need to be regulated and to make sure that everybody is actually doing what they're supposed to be doing as per their qualifications. So you need to ensure that everybody's with the HPCSA or with SANC and so forth. So that's the first thing. That's the first funnel that you would utilize to make sure that you're safe in terms of a human resource perspective. And then you have to have various committees and forums. I think you would remember that up to 2003, we've always had COSASA. Before that, there was a generic quality Department of Health division, which was looking at how it is they can actually adjust some of the principles of COSASA to make it government, and that's when the Office of Health and Compliance came into place in 2003. And so you have that, and whether you're private or whether you're public, you actually have to adhere to those different regulating bodies to make sure that you're not found wanting, and you don't have a hospital that is either closed down. That would be the worst case scenario that could actually happen. And so these bodies basically guide you, and it's really nice because it's, in a way, it helps to standardize. So even if you're in the most remote areas, you sort of have an idea of what is expected of you. It guides you in terms of what would be looked at, or if inspections are done from an infrastructure perspective, from a ratio of patient to human resources perspective, and from a package of service. And so if you are a primary healthcare package of service, what would be expected of you would be certainly different to what would be expected of you if you're in an institution that has cardiothoracic surgeons, neurosurgeons, interventional radiologists, etc. And also you belong to various license groups that also ensure that your equipment is still running efficiently, and that your equipment is actually very safe, and that it's still within the right shelf life, so to speak, and that you're not utilizing equipment that is either giving the wrong imagery or misdiagnosing patients, and so forth. And so when you look, for example, at private, similar to a state, nonetheless, you would have to have various streams of patient safety, of quality, and those things they're audited on an annual basis, or based on what your findings are. If you're found wanting, of course, you would then need to, to be inspected more frequently. And I think what's good as well is, remember, you have to be compliant with various other components, like your ISO regulations and so forth. And those also cut across quality as well. So while it still looks at environmental sustainability, it also looks at your waste. Are you using the correct service providers? They look at the whole cradle to grave. Are you making sure that your placentas are fine, and so forth? So those are the things that are utilized. One thing that is also quite important is mortalities looked at across board, whether it's private or public. And of course, that is also quite a good indicator to show what your practices are. Because obviously, if your mortalities are too high, there must be something that may be a bit of a gap, and then you would either look at the physicians and so forth. I must say I haven't really been in a space where the mortalities were overtly, an outlier and it had to be investigated. But if you're somebody who's working in state and you're thinking, how do we make sure that private sector is actually doing what they're supposed to be doing? It is all these, every single hospital group would want to make sure that they in the green light with Office of Health and Compliance, that their mortalities are fine. Even medical aids also look at these various indicators to make sure that the level of care is correct. So these are the things that one would put into place. So for the doctor in the Western Cape with a 36 bed, whether you're 36 bedded or whether you're 360 bedded, you have to have an infection prevention control committee. That's absolutely crucial, which would look at your various bugs that you might have, your hospital-acquired infections, which would look at your practices, COVID. One COVID case when in a 36-bedded hospital actually shoots up your prevalence of your COVID in your hospital. And so, do you have the correct PPE? Are you protected? Is your staff protected? Are your patients protected? Is the patient who's got COVID also protected? So that's one thing. And then patient safety as well is something that's really looked at, from fall rates to adverse events. And remember, in state, you would report them to province. In private sector as well, the different hospitals don't really work on their own. You have head office, which is responsible for making sure that they look at the various trends, because they too need to report these to province. Because I think what is also important is we like to split private and public. But when you are a National Department of Health or when you're Gauteng Department of Health, you're actually responsible for both. Remember, the beds still belong to state. So if you've got a 440-bedded hospital that's private, it actually is private in terms of how you run it and how you fund it is private, but the license still belongs to whichever province that you're in. And in that province, there'll also be a quality control IPC committee where you have to give in your statistics. And they, of course, can also do spot checks. So there are various different organizations and bodies that will look at how you're performing, and they dictate and they guide in terms of the committees that you should have. You need to have a portfolio of evidence when they come on board, and it becomes a monthly routine in terms of how you actually operate. So quality assurance is something that you do in all aspects. Even if you look at something that sounds remote, like your EBITDA, which is basically your profit, in private, you need to make sure that you stay within your margin, because if you're going down, then there's something about your business model that's not correct, and you need to try and see what it is that you can actually improve, create a quality improvement plan on that. Or if you find you've got high VAPs, why is it that you're having a lot of ventilator-associated pneumonias? And you need to look at various components. Is it your nursing staff? Is it your physios, doctors, everybody who comes and touches your patients? Is there good hand hygiene? Are you using the correct subglottal tubes and so forth? And the same thing would also apply in state as well.
And just in terms of some of the practical things that one can sort of institute as a clinical manager to sort of improve quality within a facility, can you speak about that? I'm thinking about your your mortality and morbidity meetings, medical audits, and so on.
So I think the first thing as a clinical manager is you also need to work very closely with your nursing manager. That's very important, because the last thing you want is to also have duplication of services. And clinical management, I think it cuts across so much with nursing management. And remember as well, management itself is evolving on so many different facets. So the first thing I would say is, if you're a clinical manager somewhere and you want to do something, I certainly wouldn't start with a project tomorrow and say, yes, this is it. I would really tease it out with my nursing manager and discuss the statistics, what it is that you actually see. So there are various things that you can actually do. So, you need to have definitely you need to monitor your mortalities, and rope in your doctors. Remember, the first thing I said is if you want to be an excellent manager, you need to really also listen to what the people on the ground are actually doing. And there's absolutely no way in which, if you in a corner office, you could actually come up with a program that would really speak to the actually need to do is you need to look at your indicators. You need to then rope in the specific department. So let's say now you're in a 200-bedded hospital and you realize that, you know what, actually I seem to have a very high neonatal mortality rate. Then you need to get in your neonatologist. You need to speak to the nursing team in that specific unit and understand what it is that is a problem. Then you need to drill it down to what is it that's actually contributing towards that. So that's where the EP component of it comes in as well, where you need to look at the various trends and try and find the point of source of the actual problem itself, and then you start with that. What is also very important, and in management you learn after some time the do's and don'ts, is you don't come up with the program and a solution at the same time. So you need to actually have basically an open book program that you need to take to your clinicians, or you need to take to your nursing staff, of your physios and so forth, and they need to help you fill it in. And your role then in management is to make sure that you either have quarterly meetings, monthly meetings, depending on how bad the problem is itself. So that's definitely something that you need to have. It's very critical. And also even basic things like your waste, your placentas, are they locked up, etc. These are some of the things that you can actually put in programs to make sure that you've got efficient management. But the first thing I would say is, before you put in any program, if you're a clinical manager or if you're a general manager, is you need to look at your data, because your data will tell you a story. And you can't also look at your data on your own. You actually need to look at it with your team. But also utilize your team as well when you're coming up with the program. I think that's very, very important. It's also challenging to come up with a generic program. So I'm thinking now, Sahendra, as you say, what are some of the things that you can actually bring in immediately? Because there's such a huge difference between a hospital that has got your ICUs and is ventilating versus a clinic that just has high teenage pregnancy rates. You need to look at those specific challenges, and I think that's why you learn these principles in public health, to really look at a problem from a distance, but also look at it globally, and then from there try and define the problem. Once you've defined the problem, then you'll tease out in group work with your teams, which happen to be the different managers, in terms of how it is that you can actually best come up with a formula to look to mitigate the problem. And I think also one thing I've learned is, remember, whatever it is that you put in as a program is not going to be the penultimate answer. So when you look at that PDSA cycle, you really need to plan, you do, you study, you act. But you might find that yourself and the professors and so forth have put together the greatest plan, and 3 months, 4 months later, nothing has happened. You then go back and you look at, was the problem actually what the problem was when you tried to define it? And or is it something else? And then from there you move forward with the best way to actually come up with an intervention plan. For me, I think having come out as a fresh student registrar who was now this clinical manager in private sector, the first thing I did was to call on the late Prof. Stoltz, and because IPC was a bit of a challenge, and the CAUTs, the catheter-associated urinary tract infections, was a problem. And of course, Prof would come, and you feel when you've got the big infectious diseases Prof coming to assist you, that you're going to fight this and you're going to get an answer. But when I look back now, the first thing is to actually sit down with the team, and to sit down even with the ward itself and ask them and tease out what is it that's a challenge in their ward, and what are the suggestions or solutions they think could work. And then you need to then start putting it together and look at ways in which you're going to monitor the progress of your plan.
And I think thanks for that. I think you've actually covered a lot of the theory that we've covered this week during the module. The one thing maybe we should speak about is the role of patient satisfaction surveys. So, these are done quite commonly, I assume, both in the private and the public sector. And how useful do you find those? But let's see, ask Prof. Makanyane to go ahead with her question, and then you can speak to both.
Good afternoon, Dr. Majake. Thank you for this opportunity. In fact, I was going to ask about person-centeredness as one of the key characteristics of effective service delivery, and wondering just how far institutions would go in terms of finding out what patients need from the services. Do they have a voice in determining how services should be run? Thank you.
So thank you for that question, Prof. I think the voice of any client definitely is quite an imperative one, and it's the foundation of the Department of Public Service and Admin, it's the foundation of the Act, and is translated into Batubile principles. These Batubile principles are also translated into private sector. And what I also want to emphasize is everything that's done in private is actually echoed from state. So the theory and the application thereof actually comes from state and is then tweaked into private sector in their way, based on the space that they're in at that moment in time. So I think patient satisfaction surveys are very important. What is interesting is obviously you get incentivized for different reasons. In state, you would get incentivized because number one, you need to have it. When you look at the previous Minister of Health, Dr. Alan Motsoaledi, and his, when he came up with the priority areas, certainly patient satisfaction was looked at, and of course your incentive was to get a good score for that, and also officer standard compliance. I think it's domain number 1 or 2 as well, that was quite that focused around the patient itself. You need to have patient satisfaction surveys, and I think most people sort of water them down in the sense that they feel it's about how are you and how are you feeling today. But actually they're very informative, and they can tell you a lot about your climate within a hospital itself. And you cannot render a service if you don't get feedback from your client, because then you're not really looking at the service from a biopsychosocial perspective. And I can tell you now that even if you've got the best state-of-the-art private hospital that has, solar panel, everything, if you don't really get feedback from your clients and you don't come up with measures to either make sure that you stay on that level or that you improve, your hospital will close at some point, because then you're not being responsive, and you need to be very responsive. It's very crucial. For public sector as well, it helps us to understand just what other additional requirements there are. And so Dr. Moodley, in his humility as well, came up with, the discharge lounge that's currently utilized in Steve Biko when he was a registrar. And that's because of feedback that we would get from the patients and also from the doctors as well. People get discharged and then they don't know, they hang, they don't know where to go. So you need that. And it's really a pity that sometimes patient satisfaction survey gets, it gets given to an equivalent of a care worker, or, just somebody who actually speaks well and is not taken seriously and teased out by management. But I remember when I was a general manager, some people would say, you like to micromanage, etc. I actually relied on those, first of all, to make sure that I'm sure that the team has actually gone out to see the patients and have asked them questions, but also just to have an idea of what's happening. And I found that whenever we would focus on those specific things, the scores would invariably go up. And likewise with state. State is a bit more challenging because it's very difficult to ensure that all 600 patients are satisfied. And also the problem with state is the fact that because we deal with a vulnerable, and because of the fact that there's just so many gaps and levels, people might not always be as honest when they want to give feedback. This is one thing that I've actually found. And so, when you look at the confounder is when you look at patient satisfaction surveys, when you look at state ones, they're always much higher than private. But I just think that it's the nature of how the information would be given. In private, you would have your daily sheets that you give, but you also have your press genie where you can electronically give information. And I just think because the expectation is, look, I'm paying for this service, I'm going to be open. When a patient complains in private, it doesn't really get seen as this person is a problematic person. Whereas if you're Meletlonolo in state, you almost feel like you're getting this service. It's almost like a favor, and you don't want to over complain, and so you will shift more towards giving positive than the negative inputs. And I think this is again where we need to start using more IT systems to get more information from the patients. It's very critical, but it's as critical as it is to ensure that your EC can do resusces. If you don't get the correct feedback from your patients, then you're unlikely to really make sure that you render the best service that you can actually give. So it's extremely important. And I think if you're a clinical manager, start there. Speak to your patient experience manager, ask him or her, what the common complaints are, and from there, tease out the ones that would belong to you. Because one thing I know about healthcare is that it's very territorial, and the hierarchy really matters. So of course you don't want to ruffle the feathers when you're just starting as a clinical manager. But you certainly also want to contribute meaningfully. So you just, you respectfully go and you tease out where the challenges could be, and you look at what it is that you can do to contribute towards the bigger team itself. And what is interesting, Sahendra, is also sometimes it's not even just about what is happening in the facility, but also the system itself. So it could be something as basic as when we utilize CT scan facilities in another hospital, patients get left behind or they get forgotten. So it actually helps to tease out the challenges in the system, not only in the facility itself. Yeah.
Yeah, no, I think that is an important point. I just want to look at the chat window, and I'll read these out because of the video, but I'm sure you can see it as well. This is Nandi saying, this is so informative and gives clarity on certain things that I was confused about. Thank you, Dr. Majake. Great. Then Moratele, I honestly think that quality management is a management function rather than a nursing function, because sometimes quality challenges come from support structures like procurement or patient administration. What is your opinion on this issue?
I wonder if Moratele has got does she have access to the mic? Because the first thing I'd like to know is she a nurse?
Moratele, you can just put the mic on, please.
Okay. Hi, Moratele. Thank you so much for the questions, and thank you for the comments as well to other fellow colleagues in the session. So my question is, because when I'm reading your question, what I'm sensing is, if you're in nursing, is it because you're not getting the correct support, and you feel that management should actually be more involved? Can you give some background as to your statement, and then I can also give my inputs? Okay. I can see you've unmuted, Moratele, but okay, I see you're still struggling. So while you're getting on, please just say something when you're reconnected, and then I will just halt a bit and you can continue. But I think quality, it's not only a management function, but it is management's function to ensure that quality improvement systems are actually in place in the hospital so that you can do your ongoing quality assurance. Absolutely. But remember, management cannot be in every single ward or every single clinic or every single OPD. every day, 24 hours. So we rely on the individuals that are in that specific space to help us to understand where the gaps may be and how it can be improved. And you know what is interesting is it's not even a nursing or a management function, it's everybody's function. So I'll think quickly of even patient admin. It could be something as basic as a waiting time in the reception area. It takes long for files to be opened, or it takes long for patients to go into the unit, and so patient admin would then look at, is it how we allocate the staff, what are the peak times, and how do we then make sure that we get the right people? People are going on tea when the clinics have finished, and they need to go to pharmacy, so it's different people's responsibilities. And I must say that some of the very wonderful quality improvement plans that I've seen from Steve Biko don't come from management, and they don't come from nursing either. They come from pharmacy and other domains. So I think it's just probably the way in which we think of quality and the way it's done. I think it tends sometimes to feel like, oh, then they want these statistics and they want this information, etc., etc. But when am I supposed to do it? So maybe management should actually do it. And I'm guessing, I might be incorrect, but I'm guessing that's where it comes from. But I'm hoping that after this session, you realize that everybody is critical and vital in ensuring that the quality is it's monitored, and that the indicators are clearly understood by everybody, and that the data can actually be adequately captured and teased out, and management needs to give you feedback on that, and you need to work together in terms of what your way forward would be. So are you able to speak now, Maradele? Or it can be anybody else who also either agrees or disagrees with this. I like engaging, so I think let's have a debate as well. It's good to have different components.
Yeah, it looks like I can see the microphone, but it looks like I think there might be a problem there, an issue there that the audio is not coming through.
Or alternatively, she can type in the meantime. Type the comments, and then we can just take it from there.
So students, I think we're going to move on from quality, but if there are any questions around quality, please ask those, or raise your hand, or type it in your in the chat window. I think for these African students, I've specifically not done this because we've got students from all over the world, but it's important to look at the regulated norms and standards. So that's an important document, and it speaks to what's been said, that we're looking at a number of different areas, a number of people responsible for quality, and I'll put up that link to those documents. I'm not sure, I can't remember if I've done it already, probably not, so I will, and I think just go on to the kind of the Office of Health Standards Compliance website, and you'll find some additional information there around quality. So Leshmaganola, I just want to finish off by talking about health information. I think you've touched on it at various points during this discussion, but maybe we can sort of bring it all together. And so my question is really about how health information helps you as a hospital manager do your job.
Okay, so before I answer that as well, I noticed that you spoke about the Office of Standard Compliance for South African students, but also look at the ISQA. I don't know if you've spoken to them about the International Society for Quality in Healthcare, because remember, even us as a country, we're still informed by a body that governs from an international perspective. So obviously WHO is our regulating one, which is informed by the different conventions from United Nations, etc. So if you're a non-South African student, ISQA is actually what would guide you as well. And there's various information. So NHS, South Africa, whoever, is also guided by the principles of ISQA. So that's also quite a good link to get into, or if you can just have a look at that component. So health information systems is vital. It's absolutely essential. And I think because of the fact that healthcare is evolving, it's been about the temperature and the BP and, the stethoscope and so forth and theater. And health information has always been seen as something that really is more of a component that's in the periphery. I would love to get Moradela's view, but I think historically it was probably also seen as a component that really has very little to do with, the doctor or the nurse, but actually it has everything to do with you, to be able to do your work. And why it also has a lot to do with you is because we utilize data to be able to make certain decisions. But we need your ICD-10 coding. We need that information to be able to really understand what's happening. So even if you look at the DRGs, your diagnostic related groupings, for us to really get the right type of lenses for ophthalmology, and to really make sure that we've got the right type of medication and so forth, we need to have really been given the correct information. And I think also for managers, senior managers that may be in this platform as well, case management is also quite an important component that I think seems to be falling short, particularly in state. That is really vital to make sure that we get what we're supposed to get in the form of notes that will then give us a clear perspective of what is required from the hospital, because currently we're looking at your generic information, which feeds into the NTSG. So, we look at the generic one, your maternal mortalities, your under 5, mortalities, your severe, malnutrition and so forth, your SAMs. But we also need to really have more information to help us to plan, and to really make sure that we feeding resources, very limited resources, and mind you, whether you're private or your state, resources are limited. So to make sure that you actually are feeding resources in the place that requires the most number of resources. So that's really important, and I think it's really as important as making sure that your roof is not leaking or your wall is not collapsing. So it's quite an integral component of how you run your hospital as well. And remember, health information is not it's not only just the bigger component of it, from an ICD 10 perspective, or what I mentioned before, when you look at your cost per event perspective. But it's just basic data that we use on a day-to-day base that really informs us in terms of what is required to be able to manage patients. So, even if you're sitting somewhere in a remote area, please don't be the MO, which I think we all do. When you get tired and you've seen patient number 45 and you're just exhausted and you're thinking, why are they giving me these sheets to tick things? Your either correcting correctly or incorrectly could really impact so heavily in terms of, the funding for HAST or the funding for tuberculosis, etc. So it really is absolutely critical, and we utilize that information all the way up to national. So it is important. And I think I'm also cognizant of the fact that, we are in Africa and our resources are very limited. As much as we would want to have everything electronic, it's not always practical. But even the manual bits, it needs to be well captured. It needs to be well managed. It shouldn't be arbitrary pieces of papers that don't get utilized to feed into the DHIS and to feed into the nerds as well. So it's very important.
Yeah, I mean, I could agree more. And as we all know, that health information is one of the health system's building blocks. And throughout the health system, you need this information in order to, deliver an effective service. I see Maratula has written back in the comments to say Quality management is not a nursing function, but rather a general management one. But I've seen that in public hospitals, we advertise the post looking for a nurse for quality assurance manager. I'm not sure if you want to respond to that.
Yeah, I think I did respond to it already when I mentioned that management cannot be in different platforms. And remember that a quality assurance nurse is one who really has been quite well trained, or will then be trained if they opt to get into that job in various components of quality. So this will be somebody who, first of all, understands the OHSC, who understands, the principles of, inspections, who then will also be given quite a lot of training in terms of data analysis, and how to respond to that specific data. And who would then be a steward, because when you're on that level, you're actually supposed to be there to guide your fellow OPMs or unit managers in terms of looking at their data, helping them to tease out areas that are of concern, and helping them to come up with quality improvement plans. So I definitely think the nursing cadre is definitely the best for it. And remember, they would work hand in glove with your clinical management, especially in private sector. And I think that's something that still needs to be developed a bit more in state. But remember, they also liaise on an ongoing basis with the province. So absolutely, it's a function of that person. And I can't think of any other person that could do it. Definitely not a CEO, definitely not a human resource person. No. They really are the best. Just also on data, for the people who do data, who like data analytics as well, and also for the actuaries. I hope we've got an actuary here. It would be nice actually to have one. Is that, remember, you also need that information for what we call case rates. So if we don't have all the information to really guide us on the type of cases, we can't project. If you in funding, if you're medical aids, you can't project in terms of the types of packages of services that you would actually render to specific clientele. If you're in state, it becomes very difficult to then understand your business units and where your focus should be to ensure that the HODs can run the units as effectively as possible. If you're in private sector as well, it becomes very difficult if you don't understand your case rate to plan on the type of specialities that you want. So remember, you would go and source various doctors, so it becomes very difficult to plan on that. It becomes also difficult to know what type of nursing staff do you need. Do you need a professional nurse? Do you need an ICU trained professional nurse? So you need that information to be able to plan various things. So it's absolutely crucial.
Yeah, I couldn't agree more, and I think it's important to stress the impact that this health information has in terms of resource distribution as well. So if one takes something like your bed utilization rate. So if you're in a hospital that has running at 50% bed utilization, maybe that means your resources need to go somewhere else.
100%.
And
also, sorry to interject, Zenda, but also in private, you would do the same thing, hey? So okay. You would also look at, if you're 50% and you look at your nurse ratio. So do you still need the number of nurses that you actually have for that night? Or would you rather contact your sister hospital to find out if they've got shortage and put them there? So, it's the same principle that would actually feed across both areas.
Yeah, so surprisingly, you've kind of identified lots of commonalities between private and public sectors. So maybe it's not that different after all. I think we are running out of time, or we have run out of time. So let me thank you again and close this session. I think it's been very useful for the students to bring all of their work together and kind of see it from the hospital management perspective. So thank you again so much for your time. And we've obviously trained you very well at the School of Health Systems and Public Health, and continue doing us proud. Okay, so I don't like leaving questions, so let's just answer the last one here from Prof. Mokonyane. How I think maybe it's how far is the Department of Health from activating a national electronic database? My experience has been that patients embark on medical tourism, visiting whole hospitals, and end up on, for instance, waiting lists for 3 or 4 hospitals. This in turn then inflates statistics that departments submit to management. I think, yeah, that's a good question. Any ideas on that one in terms of this electronic database, which has eluded us for 2 decades?
Yeah, I think it's a very important question, Prof, and it also just might also give some context as to why do we find ourselves having various challenges in some components in different provinces. Remember, national can make recommendations, but the provinces have got their own autonomy almost to make decisions in terms of what they can do. So even with the electronic, health records, if it was something that was completely owned by national, and national could then implement it, I think by now would be very far. But currently, provinces still have the option of deciding what type of electronic health records they're going to utilize, who the service provider is going to be. And I think if you look back around about 2000 and I think 2003 or so, Gauteng had already started doing a bit of work on the electronic health records. But every time we changed leadership, different things would come up. And so these are the problems as well. On the one hand, of course, we want to decentralize power and ensure that you run health systems as optimally as possible. But on the other hand, it comes back to be exactly what is happening now, where you find that certain things or certain in the building block, certain components of the building block or certain provinces are at a standstill. So unfortunately, it's not from a national a problem. And the barrier is not from there. It actually is from the provinces themselves as well. And it would really make sense to make it a national thing, but the structure is such that provinces still decide.
Yeah, I think, and I think the Western Cape has made some progress on that front. I think, from their sort of patient database, you're able to get a lot more information than in the other provinces. But the other thing would be, if I think there's some talk that the EVDS, is kind of really the start of a national database, because I think some of the elements that you would need for a national electronic database, we already have in terms of EVDS. So maybe that's one good thing that might come out of COVID.